chat box, but remember, if you have questions, to post them in the Q&A box, and we can answer those separately, either as they come in through typing, or we'll do it at the end through a moderated Q&A session. Today we have 3 speakers with us. The first is Nancy Glass. She's a professor at the Hopkins School of Nursing. She works domestically and internationally with a focus on gender-based violence. Very importantly for me, she's an associate director of the Center for Global Health. She and Michele Decker, our second speaker, are co-directors of the Gender Equity and Justice theme of the Alliance for a Healthier World here at Hopkins. Michele is an associate director in associate professor in the Population, Family, and Reproductive Health Department at the Bloomberg School of Public Health, and her research focuses on social determinants of women's health and gender equity with an emphasis on gender-based violence. I hope that wasn't too much, Nancy. I know you said keep those introductions small. And then finally, we have Catherine Tallam. She is a business development officer at Ujima Africa, which is an organization based in Nairobi that focuses on empowering women and children, providing them with skills to prevent violence. And I understand Catherine has been working together with Nancy and Michele on some projects. And so the 3 of them will be giving our presentation today, and then at the end, answering any of your questions. So I'll turn it over to you. Perfect timing, Nancy. That was my alarm to stop talking, so thank you. And
turn off my phone.
Over to you, Nancy.
So thank you, everyone, and welcome to our session on really focusing on gender-based violence, and I'm sending greetings from Baltimore, Maryland. So what we want to cover in this presentation is we want to first focus on and just discuss the 2 overlapping pandemics of gender-based violence and COVID-19. And we're going to specifically focus on, in this session, primarily on intimate partner violence. And we're then going to talk about some of the strategies we can use to support women and girls in unsafe relationships, to support their health and safety during this pandemic and beyond. And we're going to introduce you to some work that we've been doing over several years, which is a technology-based intervention, which is free, it's secure, it's private, and it's web-based. Safety planning app for survivors and concerned friends and families. And we're very lucky to have our colleague from Ujima here, because Michele and Catherine are going to speak specifically about the work we've used to adapt my plan to the Kenyan context. So first, let's just make sure we're all on the same page about what is intimate partner violence. So when we talk about intimate partner violence, we talk about a pattern of physical violence, sexual violence, stalking, or psychological aggression. And it could be a current partner, or it could be an ex-partner. And when we say partner, we mean husband, boyfriend, girlfriend, and certainly the ex-partners. So maybe separated or already divorced from a partner. What we know from the work, especially led by the World Health Organization, is that 1 in 3 women globally will be abused by a partner or ex-partner in their lifetime. So, and that is a global, consistent across all the WHO regions. And all genders experience intimate partner violence, but women and girls are at highest risk for frequent and severe physical or sexual violence that can often lead to severe injuries, and in the most severe cases, intimate partner femicide, or the murder of women. So why do we really want to talk about intimate partner violence and gender-based violence in the context of COVID? So since intimate partner violence, we call it a public health pandemic because 1 in 3 women in their lifetime are going to experience that. So now that we're in the situation of COVID, which is another global health pandemic, we wanted to think about some of the strategies, additional abuse tactics that partners may be using during this crisis. So a partner may be taking advantage of stay-at-home orders and limited access, the woman's limited access to the workplace, public spaces, or public transport to exert more power and control over their partner. We know that all the factors are in place for increased risk of violence, unemployment, lack of access to typical resources in the community, lack of access to support services. That could be your church group, that could be co-workers in the workplace. By staying at home, you may not have access to those support systems. And then not being able to go to work, being home, taking care of children, trying to educate children in the home, an increase in alcohol related to the stress and trauma of this pandemic are all situations that can increase risk for violence. We also have seen cases where a partner may refuse to purchase cleaning supplies or health supplies for the family as a way to control the situation. We also may want to, we see that the partner may share misinformation about the virus or set up a situation where a woman can't have access to her phone or information or talk with people that, that she loves and get support from, so further isolation. And then prevention from accessing health services or medications that she may need that may not be directly related to COVID, but she may need for other health conditions, or the children may need for health conditions. So we're seeing these additional tactics that really demonstrate what violence against women is often about power and control. So we also know that there are going to be fewer options for women to seek help. Survivors may be too fearful of the virus to seek services because of health risks to themselves, their children, and other family members. If she goes out of the home to seek services from a counselor, a faith leader, a friend, she may be risk of contracting the virus and then bringing it home to her family. So she may want to avoid that for the safety of her family. Lack of opportunity to contact those services that have been very supportive to her when partner is always around. And closure of many in-person services. So we know that partners are, if violence increases, many women may want to seek shelter outside the home. They may want to go to the counselor. They may need respite and want to go to family members, but they're not able to travel. There's no public transport. They're not able to seek those services. So women are then staying at home and not getting the support they need. So seeking safety, we wanted to, survivors can create a safety plan that may also make the added stress of COVID feel more manageable. We're not talking about a safety plan to leave the situation. It just may not be feasible in the context where she lives. She's not going to leave her husband or her partner or her children. But we want to talk about safety when she's in the home, safety for herself and her children and other family members that can be at risk. So we want to help women develop a personalized, practical plan that includes strategies for survivors and their children to stay safe and cope with abuse while in an abusive relationship, or when they're planning to leave, if they really have to leave for safety for their family and children, how do they leave safely or after leaving? We know that when women leave the abusive relationship, it can oftentimes be the most dangerous time. Their partner may feel that they've lost control over the relationship, and they may say, well, if I can't have her, no one can, and that she may be at risk for very severe or lethal violence. So what we want to talk about a little bit today is the work we've been doing over the last actually 10 years around using technology and leveraging technology to empower safety planning for survivors and their concerned friends and family. An app for people, we really divided, my plan as an app for people to identify and make safety decisions about their relationship. And it also can be used by friends and family members who are concerned about what they're seeing in a relationship, or concerned about the impact on the children or the woman and how they can support her or help her. Many of us want to help our loved ones when we see stress in their relationships, but we're often concerned, we're afraid it's we're afraid to get involved. We don't want to be rejected by our family if we talk about our concerns for their safety. So we oftentimes don't say that we recognize the issue and we want to be supportive. So this is a sample screenshots of the MyPlan app, and we'll give you information about how to access it. It is accessible for free. We have devised it to have a security pin, and we're very concerned about technology and safety when using technology. So there's a lot of information about how to use this, and then if you need to remove it from your phone, understanding that partners may be very sophisticated on reviewing your phone. So thinking carefully about technology safety and if this is the right resource for you. It may not be, but you may ask a friend or family member to download it if they're in your home and you can use it on their phone or their device. Globally, you would have to use the web-based app. It's not, we don't have it in each country yet for download from the App Store, but it's available as a web-based app. So you would need to go to the website and use it, and it can be downloaded. So we really are focused on accessing the health and safety of a relationship. So the woman or the young woman can enter in information about her relationship. We look at how we do an assessment of how dangerous the situation is. Has the violence increased in frequency and severity over the last few months? Is the partner using alcohol or drugs? Is the partner threatening the children? These are all indicators of increased risk for severe violence and extreme violence. And then we personalize that information based on their risk assessment, the woman's priority for safety. Oftentimes, if there's children involved, her priority is going to be protecting the children. We then provide a plan that connects to resources. And for example, in Nairobi, we connected to the local resources that are available in Nairobi. So it's not just a resource for survivors and their concerned friends and family, it's also a resource for healthcare providers and advocates. Many healthcare providers are seeing women in their practice or seeing them, talking to them on the phone and helping them talk through a safety plan, or doing telehealth. Helping them talk through a safety plan is really important. An app is not a replacement for expertise. This app was developed as a intervention, a safety planning intervention that's delivered through the most appropriate technology for the woman and the setting. And so healthcare providers, community health volunteers, community health workers are excellent resources to provide this with a woman, walk through safety planning with her and help her develop her personal safety plan. So it doesn't have to be used only on a survivor's smartphone. It can be used with providers in the healthcare setting or advocates and counselors. So just to sum up the work we've done, we have done clinical trials. You know, we're very interested in, and I know all the colleagues on this webinar are interested in supporting evidence-based interventions. So we don't want to advocate for a technology-based intervention like MyPlan if we don't have evidence that it is helpful, and certainly we don't want to do harm. So what we have found through the trials that we've conducted 2 trials in the US, a trial in Canada, a trial in New Zealand, and a trial in Australia. And Michele will talk a bit about the trial we just completed in Nairobi in partnership with Ujjayi. So what we found that in the US-based trials is that it reduces decisional conflict, thus increasing ability to make safe decisions. So women feel like they have the information and the resources to make safety decisions for themselves and their children. It also increases the use of safety strategies that they find helpful for their own safety and well-being. So tailoring or personalizing a safety plan helps women use strategies that are based on their situation and their context, rather than just providing a general safety plan. We compared MyPlan intervention with usual safety planning. And it also increased women who are deciding to leave the relationships, who have made the decision to leave. We found that women who use My Plan were more likely to be able to leave that relationship safely compared to usual safety planning. They reported a decrease in violence, specifically psychological abuse, so making threats or insulting their partner or threatening the children. And also we saw a reduction in sexual violence. And then we found in our sample of young women, 18 to 24, it reduced reproductive coercion. For example, reproductive coercion is really understanding that a partner may be trying to control the relationship by refusing to use a condom, demanding that she gets an abortion when she wants a child. So these are things that we looked at specifically with young women. And we also saw reduction in risk of suicidality for these young women compared to women who used a usual safety plan. So we think tailoring safety strategies to the needs and context of the women is the real benefit of using the My Plan app, as well as having it available 24/7, secure and confidential. Now let me hand it over to Dr. Decker, and then she'll introduce Catherine. Thank you so much.
Great, thanks so much. I'm so glad to have a chance to share some of the work that we've been doing in partnership with UJAMA in really testing and adapting the My Plan tool to this environment. There is, as many people are really well aware, there are great needs for violence prevention and response and safety planning really pretty much all around the world. And even where services exist, sometimes there's a gap in getting people connected to those services. All of the social stigmas that prompt people to not reach out for care and services, these are some of the places that the My Plan app can be really useful. So we set out to do this adaptation and testing really for the first time in Nairobi. This is a project that's been about 3 or 4 years now. Oops, sorry, can you back up just a bit? And basically what we did with this, could you go back to the, yeah, oops. I'm gonna let Nancy pull the slides back up, but I will tell you basically about the process that we undertook, which was at the time that we started having these conversations about bringing My Plan to Nairobi, there were some real questions about sort of app interest and app use and app uptake, et cetera. And then there were some real questions that we wanted to answer about how it could interface with a service delivery environment and how it could be used in that setting. Sorry, could we get the slides back up? Thank you so much. So we really started with a formative phase. We talked to service providers. We talked to women that were experiencing abuse. We ran a series of in-depth interviews, focus groups, everything sort of in terms of how could the app be most useful? Oh, super, thanks. How could the app be useful? Would it be of interest for people? And how would they like to use something like this? So we got a lot of feedback in this phase. It may not be surprising at all to this audience likely that some of the points around sort of leaving a relationship safely were not as relevant for this environment, where there are barriers to disrupting families, where there is great pressure to keep that family together. The emphasis then became on how to stay safely, how to reduce risk, how to reduce risk for children and keep children safe. So a lot of the adaptations that we made to the safety strategies were very much about creating leverage in the relationships, keeping children safe and inspiring people to think of ways that they could do that safely. And we also did quite a bit of sort of content simplification, adding graphics. We did an extensive mapping component so that we knew that the referrals that we were referring out to were really useful and going to be able to really support women. And then finally, we also, in this environment, we kind of framed this as community partnered technology in the sense that many women expressed a preference for going through the app for the first time with someone else. And so when we implemented this for the trial and the piloting, we trained up a cadre of community health volunteers to help women go through this app for the first time. I'm really going to let Catherine talk a lot more about that, but I do want to tell you just our trial results. We implemented a trial with just over 350 women, and we followed them only for about a 3-month period. We really considered this sort of that first step in, again, that adaptation, how well does this work, et cetera. But similarly to what we've seen in other environments, we saw really a positive impact on safety behaviors and safety preparedness at that 3-month follow-up. What was also really interesting and kind of an unintended but very, very sort of wonderful anecdotal report from this as well was that our community health volunteers, by going through this app over and over with women in our study, really built a lot of confidence in that GBV response. And so there's some value that we see with this as actually a job aid in helping people that may be frontline responders to violence, using the app to really hone those skills and be able to give that information further. And with this, what I really want to do next, Catherine, I'm so glad that you're here. I want to turn over to Catherine Tallam, who is part of our core leadership team in all of the phases of adaptation, all of the formative work in the piloting for the project, and is really centrally involved in the trial. And she can tell us a lot more about what this looks like on the ground, what women really liked about it, and sort of that lived reality experience. So thank you. Catherine, over to you.
Hi, okay, this is Catherine. We'll talk about the experiences of women and the CHVs and the people that you work through the project with. All through the project, women felt that the app is useful in that they felt that it's more or less judgmental, because once a woman goes into the app, it's her maybe with the CHV alone, and they're able to go through it, they're able to rate themselves, rate herself, and be able to get an answer or something that it's her herself that can see, and it's not judgmental. The app also is easy, it's easy to use, even if the first time during the baseline, most of them were assisted by a CHV, but when they came back for the follow-ups, most of them preferred to do it themselves, meaning that the women felt that it is easy, it's relatable to them, and they can be able to use it alone. And then most women loved the videos and the graphics, so it was easy for them to be able to go through it and understand it more through the videos and the graphics here. So for me, and most of us who worked in the project, we liked it because when they came up for the follow-up now, it was easy for them. They were able to go through it and relate with it, and even ask questions where they felt like they did not understand, or when they wanted to know more about the information. So that's what I liked most. And then during the control, people wanted so much to go through the app. That's sure that even if they got a little during the baseline, when they came up for the follow-up, they wanted to know more, meaning that the information that they got, it was helpful, and they wanted to know more that can help them to be able to fight or to combat the violence that they're going through. Yeah. So most, I can say most of them felt like the child strategies were really helpful, and personal help. Even all the others were helpful, but those were the ones that mostly they felt were helpful to them, because they felt like the children were also going through they were being affected by the violence without even them knowing. So most of them even did not know that they can speak to their children about the violence and let them know that it's not their fault, and just help them to cope up with the stress that comes with their mother or their parents when there's violence in the house. Yeah. And then also on the My Plan, there is a part about violence, and most women, there's so much conversant with violence on physical, sexual, so they didn't understand more about violence. But on the section about violence, if you go through the woman with that section, when they want to know more about violence, you'll feel that they're able to relate, because there are small stories that were there from other women. Of course, the names were changed, yeah. So they were able to relate and to be able to understand more about violence on that part. And it was really helpful for women to be enlightened about the various types of violence, and to be able to know maybe they are going through that without even them not knowing, and at the same time it was derailing them, yeah. And then also on the harmful beliefs about violence, yeah. Through the harmful beliefs, the women came to understand that there are some myths that are there in the communities, in their cultures, that tend to make them think that that's okay, that's right, but no, it was not right, because they are going through violence, and the myth should not be able to cover it up for it. So you find most women felt like it's because maybe he was drunk, he had used some drugs, that's why he was acting the way he was acting, maybe because he's the one providing, so I should persevere. But with the enlightenment, the women are able to at least respond to the violence that they're going through, yeah. And then one thing to note that on the resources part, the women felt it's easy for them. You know, when you're in the app, you get the information yourself. It's easy because you can connect to MSF, you can connect to Wangu Kanja without asking someone else. So it reduces the issue of low self-esteem and what is it called? When you're trying to tell someone, so it reduces that aspect that I have to ask someone for that number. Yeah, so you yourself can be able to go through it and get the number of maybe MSF, the chief, or a certain CHB, and be able to connect with them directly. I think that's important, because if I call someone and ask them, if I meet someone and ask them, do you have a number of a certain CHB who deals with maybe violence? They'll want to know more. Why am I asking? So meaning it will spread wide, and maybe I'll feel my dignity is at low. But if a woman is able to get that information from the app, which most of them have gotten it, it's easy for them to connect directly, and it takes lesser time for them. Yeah. And then most CHBs felt like the app eases their work, because you see, especially on the my relationship part, on the red flags, and my relationship part, and then that part, you feel like when it comes, maybe the results come that maybe you're in danger or in a very unhealthy relationship. It's not that it's coming from the CHB, yeah? So the woman gets more confidence and be able to know that she's in danger, the relationship is unhealthy, because it's not a person that is telling them that this thing is unhealthy, this thing is you're in danger. So they get more, they get more confident, and they believe more, and they're able to act more. You see them asking for the referral services, they want to get help, and I think that has boosted a lot. Yeah, they don't feel like it's a bias from the CHB maybe to tell them that they're in danger or they're unhealthy, because it's something that comes from the app itself. Yeah, and then most of the women felt like they need to go through the app with someone to help them go through and to elaborate more, and they feel appreciated by the CHBs for the emotional support and the helping with the explanation. And then learning experience for working women with women in the community. So at least most of the CHBs got to learn a lot. I personally learned a lot through the app itself about the violence and what the women around those areas are going through. And at least it enhanced our knowledge and our capacity as Ujamaa Africa. Yeah.
So thank you, Catherine and Michelle. So this is some information about how to access my plan. It is a web-based, if you're outside the US, you would need to download the web app. Otherwise, in the US, you can use it through the Apple Store or Google Play. And again, it's free and it's password protected. But do think with your clients or your friends, or if you're referring this, make sure that they're thinking through the safety of downloading this to an app or an iPad, and who has access to that, and will it be safe? We call it My Plan because it could be a calendar, it could be anything. So it doesn't speak directly to that this is for survivors of partner violence. And then we will upload this to our CGH site, but we do have additional resources for protecting children, and other information for survivors and programs, service providers and programs globally. So we want to thank you for spending some time with us.
Great, thank you so much, Catherine, Michelle, and Nancy, for this presentation discussing a bit about challenges of gender-based violence during COVID-19 and a discussion about My Plan. There are a lot of questions in the Q&A about My Plan itself, but I want to take us back just a minute and think a little bit more broadly about COVID-19 and what's going on now, because a number of people who have been joining us on these calls are really implementing partners, some of which who may have access to the app, others who may not. And so what are some strategies, especially Nancy, as you think back in your earlier presentation, right, you're talking about the different ways that that people might be experiencing sort of increased reduction in access, not being able to go out. What do you recommend as some strategies for dealing with this during COVID-19, in addition to this app that you have created?
Absolutely. So some of the things that we really are focused on, there's, first, helping women assess the danger in their situation. So, for example, in the U.S., as everybody knows, a lot of households have weapons. They have guns in the home, and in a violent situation, in an unhealthy relationship, if conflict increases, and as I said, all the factors are there for increased stress, mental health issues, alcohol, poverty, all of those factors we know increase risk for violence. And then there's a gun in the home. The partner may reach for that gun during a conflict. So what we talk a lot about is, in any way possible, disarming the gun, separating ammunition from the gun, asking the partner to put the gun in a safety box, locked safety box for child safety, so focusing on child safety. And then also always having a room in the household that you can move to that the gun is not in that household, and making that the place you go to quickly where the gun is not there. And then also trying to make that place you go to for safety have an exit. Is it a back door? Is it a window you can get out quickly? Is it on the first floor? I mean, these things are women often have to make quick escapes. And also having the conversation with children. Depending on the age, let's say you have a toddler. Toddlers, as Catherine said, children are recognizing what is going on, and they want to come be close and support mom and help mom. So talking with the child about going to a safe place if the voice is raised and the partner starts to threaten or hurt her. And that also teaching them how to call 911, teaching them to call a neighbor and say, we need help. So those are things that young people can do. The other thing is, if you have an adolescent, older child, talking to them about not jumping in to protect. That's when the child may be injured or hurt, and it could escalate again. Also talking with that adolescent to go to the phone, call for help. And so those are strategies that really talking with children. But finding a safe place in the home is really critical, and thinking through that, and having a backpack that if you need to leave quickly, you have some basics, and that your children know when you use a code word with them, you need to go. So those are some things we talked through, but also we want to really emphasize self-care. This is a very, very stressful time for everyone, but women in an unsafe relationship especially. So thinking about ways that they can spend time with their children separately and playing, but also taking time where they can have a few moments by themselves and do things that make them feel better. It could be prayer, it could be music, it could be dance. There are many things, meditation. So, we want to really emphasize self-care and this stress as well. Michelle, or Catherine, do you want to add?
Yeah, I will add, I think for all of us that are in positions where we're working with community members, doing COVID prevention, COVID testing, COVID response, getting the PPE out, all of this, one of the most important things that we can have on our minds is connecting people to resources. Because we know that these are the conditions that globally are going to potentially amplify or create risk for violence, a very simple thing that everyone on this call can do is find your local resources in the communities that you're working in. Make sure that you're ready to give that out to people. And one of the things that, you know, we can borrow from the WHO guidance on clinical care on this, in the sense of, we don't need to wait for people to tell us about abuse that they might be experiencing. Rather, we can get this information out to all people with that normalizing statement around, look, we know this is a problem in your community. We know that this is an issue that's caused by stress or can be amplified by stress. And we want everybody to know that there are resources available, there are confidential supports, and be ready to give that information out in a way that says, look, you might need this, someone you know might need this. If you can use this, please make these, make these calls. In many of the places we work, there are services available, but there's often a gap in terms of getting access. We can help people think about how they can make that call privately. Is there an SMS option? We were lucky to have that in Nairobi, and many of the places that we work globally also have an SMS line for more privacy. So one of the things that everyone can be part of is being that conduit and that connection to resources. So that's probably the other thing that I would add to this discussion. Catherine?
What I can say is that I think what's important right now is to ensure that there are ways that women can be able to reach to their resources, to the resources around them that are easy. For example, in Kenya right now, we have curfews as from 5 a.m. to 7 p.m. So there are strategies that need to be put in place, or resources that women can be able to reach maybe after that, or a way that they can be able to plan their strategies, their safety strategies, even before those times. Because right now it's kind of hard, but we're hoping that the women will be able to cope and be able to plan their safety. Yeah.
Thank you. And I think part of what you're talking about in terms of resources gets to one of these questions that's here about advice for clinical care providers to be advocates for their patients who are experiencing gender-based violence. Anything you would add in addition to sort of sharing resources or directing them to resources in terms of advocating for patients right now?
Yeah, advocacy is key right now, and a lot of that is if providers are coming to you through telehealth even, or being really thinking about trauma-informed care, saying to the patient that you believe them, that you know this is very stressful. Everybody should be free of violence in their home, because we know that women are often said it's their fault that the violence is occurring, that because they did something, that's why they had to be hit. So there really needs to be that, first of all, telling the woman you believe her, telling her that this is an important issue and she deserves to be safe, I think is critical. And then talking through her about some of these strategies. Asking her some questions about, are there children in the home? What is she already doing? What we know is women on a day-to-day basis are doing things to keep themselves safe. And in this situation, a lot of focus could be on helping them develop strategies to de-escalate. When a partner gets upset, we're not talking about placating violence. We're talking about strategies to de-escalate, calm down the partner, strategies to walk away with the children, to take a respite in another room, distracting the partner with other activities, encouraging the partners to do things that make them feel healthy. So I think it's really about reinforcing what strategies they're using that have been helpful, making sure that they know about shelter hotlines or chat, but also making sure they're thinking about their security and safety, and using any of those resources is really important. So I think that one of the things that women tell me over and over again is just reinforcing that they're not crazy, that this is happening to them, and that it's scary, and that you're there to listen and support them.
So now I'm going to dive into some questions about my plan, since a lot of them have come up. And there are specific questions in the chat box about where this app can be used. But Nada asks if there are challenges for the app using it in areas or populations with low socioeconomic status. So perhaps weaker internet connections, lower health literacy, comfort with technology, age, and if you have any suggestions for these challenges from your experience.
So I'm going to hand that to Catherine and Michelle, because they were able to adapt it and use it in the settlements in Nairobi.
Catherine? Oh, Catherine, you're muted.
On the part of the smartphones and the internet, I can say that once my plan is, you've already downloaded it in your phone, you won't be needing the internet again. So as long as the woman has the app itself on her phone, she can be able to use it. And then the use of CHVs has been really helpful, and most women say they can use it through CHVs. Here in Kenya, CHVs are really helpful in seeking services, especially health and safety. So they can be able to reach to a CHV and be able to go through it. And maybe if there's some information that they need, the CHV can note it down for themselves, and then maybe they can keep it safe in their house, maybe with a contact number. And maybe with the safety strategies, the CHV goes through the safety strategies with the woman and be able to make her understand what it means and be able to elaborate more for her. Yeah.
Catherine, can you describe a CHV, a community health volunteer, what they do in the health system in Kenya?
This community health volunteer usually helps with the programs, especially government and non-governmental. They help in providing the health. They usually help in issues maybe with immunization, gender-based violence, and also to get out information to the community about this several issues on public health. They usually given trainings on counseling, on maybe HIV and testing, on reproduction health. So they are more informed about issues in the community. The community health volunteers usually come from the community itself, meaning they live among the women in the community. So the women are able to reach out to them easily. Yeah.
I'll also add, I think one of the approaches that we, and Catherine, thank you so much for sort of giving voice to the CHV process in there. I mean, I think when we did those initial conversations and those initial groups on how it could be used, we really just realized, like, you know, we had to really have an array of options. Some people will be able to download it on their smartphone without an issue. Others are going to want a person to work with them on it with a CHV, and they may also have phone, whether they're phone sharing, where there are privacy issues around that. The web-based option is also available, and so it's really just about sort of matching the availability and the need to the capacity and the sort of the tech capacity there. And so we expect that there are going to be just a range, and we want to be able to really meet that. And I think the CHVs within that are such an important conduit. And they also provide, again, just that sort of that reassurance and that validation coming from a person, kind of what Nancy was speaking about. So you're not just reading it, but you're actually hearing those words around non-judgmental support, validation of those experiences. And so I think that really also amplifies the experience for those that wind up doing this with a CHV.
Great. What aspects of my plan have been sort of contextualized? So what language options does it carry? Thinking about usability, can people without access to a smartphone benefit from this? And then one question I've seen a couple of times is, can men use my plan? So
yes, my plan was created for all genders. So it is available for male survivors. The one caveat is there's not as much research about the assessment measure, the danger assessment. So we do provide a risk assessment for the male survivor, And then resources, again, and this has been just done in the US. It hasn't been, there's not as much evidence to support the intervention with men. But I do welcome and think that that's a very important question and a very important area that needs more resources for. So we welcome people's expertise and sharing of those resources. Michele, do you want to follow up on the adaptation and the language?
Yeah, absolutely. So there, with the Nairobi version that we adapted and tested, it's available in Swahili as well as English. And a lot of the adaptations were visual, sort of making sure that it was visually sort of simple and just streamlined. We found in the piloting in particular that it was, women were really reading the information word for word, and it took a long time. So we had to prioritize some sections to help them get through that risk assessment and get more quickly to the safety planning, and then make some of the other information more sort of optional or background information at their leisure to go through. And then the other key, I think, for us in that adaptation was just expanding and tailoring some of the safety strategies around ways that space could be created within the relationship without leaving that relationship. And again, sort of building in, we talked a lot in our focus group discussions and with our stakeholders around strategies, again, with children. So especially with the population density of Nairobi, but other settings as well, creating code words with children, being really directive with children on what they can do, creating code systems with neighbors about when and if they want some interference or someone to stop by with an errand or a favor, etc. So those were some of the ways that we tailored the strategies. But the core concepts, again, which Nancy really articulated, are around validating those experiences, tailoring the safety strategies based on her priorities for privacy, children, economic stability, etc. And then the danger assessment, of course, and then the connection to services. And that's the connection to services is always also going to be localized. So those are some of the ways in which we adapted it for the setting.
And does the app require a smartphone?
No, the app does not require a smartphone. It can be used on any computer. Through the web-based app. It's also available in Spanish as the other language that we have it in.
Okay, there's been, I guess, so is it available in any other country besides Kenya?
You can, if you want to use the web-based app, it's available, but it hasn't been adapted to those countries. So the adaptations have been right now are underway in Kyrgyzstan. For example, we also are adapting it in the Persian language. And so it's coming online in Canada and New Zealand shortly. So we're always working with partners. We're working with partners in Thailand and Ghana to adapt it. We do recommend that we adapt it to the context because resources, one of the key things, again, is for women to be able to reach out to resources when they need it. Call someone, have a chat with someone who knows, is an expert or an advocate. It's not about leaving or staying in the relationship. It's being able to talk with women, someone who they feel safe with about what's happening in the relationship and what are strategies they can use to plan for safety for themselves and their children. So it is really about, I'm always cautious. It's a resource for women and for health providers and others to support safety planning. It doesn't replace all the important work that's being done by advocates in the community, by hotlines, the police. So it's one component of services. And when we're in a situation like COVID, having access to resources through a phone or through the internet may be helpful for some women.
Yeah, I think there are a lot of questions here about what do you do if you don't have access to internet, you don't have a computer or a smartphone, are there ways to adapt this intervention or pieces of this intervention to severely resource poor areas with minimal phones, little data availability, because other things are just a priority?
Great question, and that's what we've done in Nicaragua. We've adapted the material around safety planning into a very visual, booklet that really shows women visually and with language on how to develop a safety plan. And so that can be provided, and that work has been done by Mary Ellsberg at George Washington University. So what you could do is go through the app if you had access, and then use that content to provide it through a resource page or a guidance. It's, this is just, the information is very useful for women who just want to, if you're just talking with your friend. So it doesn't have to come through a smartphone. And we have a toolkit on the website that will help you think about how you can use it in your setting.
Well, I will say it seems like there's a lot of interest in adapting this app in different places. I've seen some comments from Ethiopia, from Tunisia, questions about availability in French and Arabic. So I imagine your team might have some work cut out for you in the future. I'd like to end, I think, on this one question, really thinking about how gender-based violence is such a silent epidemic. And that really now, I mean, some of this is really coming to light. I mean, I remember reading the news, and this was sort of one of the first kind of things that we saw emerge, at least in US news sources, right? Sort of thinking about increased risk of gender-based violence because people were being at home. And so is this an opportunity to shed more light on this silent epidemic, and how can we take advantage of what's happening to really put this at the forefront, create new resources, and engage more meaningfully in this space?
Well, I think one of the things that we're seeing, and I think that we need to really advocate with our policymakers, our legislatures, is there documenting, talking with hotlines, is there an increase in calls coming in? Are the police getting more calls to domestic violence? And we can do that in communities all over the world. Start to document this rise in women asking, and young women as well, asking for help, as well as child abuse. I think we have to look at an increased risk of child abuse and child neglect with the stresses in the household. So looking at local reporting patterns, and then, I don't think we need to put as much research into documenting that there are increases. We know by all the researches we've done for years and years that these are all the factors that put women at risk for violence. Poverty, stress, poor mental health, alcohol. We know that these are the factors, and these are exactly what's happening in communities. And then add on that the isolation. So what we need to do with our leaders is to advocate for services, to keep funding going to hotlines, to keep funding going to community health volunteers and health clinics that are really critical resources in the community, and keep training police about how to respond and trauma-informed care. These are the things that if we advocate for resources, we want to make sure we're focusing on prevention, but also supporting the response, because with these increased calls, we're going to need to be able to better respond and more quickly respond.
All right, any final words from any of the other panelists, Catherine, Michele?
Maybe one last comment building on, I think, what Nancy laid out in terms of the need for services. And with the attention on COVID creating conditions that amplify risk for violence, we also really want to remember that we've had really stunningly high levels of violence before COVID. Right. So we want to be really careful that as we use this opportunity and as we know that there's a need for more services in this environment, we want to be really careful that we're not assuming that when COVID is over, we won't have any more violence in the world. I think the research that has been done on homicide, on health impact, on prevalence over the past 30 years has told us that this is a silent epidemic. This is a sustained epidemic that we've seen globally that is taking the lives of women and girls predominantly worldwide. And so we need to use the tools that have been developed and continue to support and lift those up when we're thinking about how do we adapt to this new COVID environment. So just a point on that. Yeah, thanks. Catherine, anything else from you?
Catherine, did you have any last words for the session?
I think on this COVID-19, what is important is women access to the services around them, and especially the community resources around them, because that is what is helpful right now and useful right now. In the Kenyan context, for example, even in Nairobi, you'll find that there is a cessation of movement from in and outside Nairobi. So there are some strategies that they cannot leave, but if they can utilize some confidence around them and some resources around their communities, that is what is helpful right now, because with the women and the families staying at home more, violence will tend to grow or will increase. So I think the resources around them is what is important right now. Yeah.
Great, thank you. So maybe a very final quick question for those who were on the session today or who are going to watch the recording, who are interested in pursuing an adaptation of this app or thinking through strategies. I mean, I don't want to just share your emails and say the best way is to email you, but is that the best way if there are people interested in pursuing this? What would you say?
We have, please go to our website, www.myplanapp.org, and we have a, I'm going to just share this real quick. If you go to the website, you can, we have an email that you can email us and we will follow up with you with more information. I do want people to think, think carefully about if this is the right resource for their setting. It's one resource. Again, the information, we'll be glad to send you the content, and you can adapt it for paper use or for flyers or for training material to in your community. It doesn't have to be delivered through an app. This is just if you have the right technology in your community. And we're glad to have discussions about how we can be supportive.
All right, thank you again to our panelists. Thank you, Catherine, for joining us from Nairobi today. For those of you who want to stick with us on these sessions, our next one is next Tuesday, as always, Tuesdays and Thursdays, and we'll be talking about the economic impact of COVID-19 with Dr. David Bashai. So again, many thanks to Nancy, Michelle, and Catherine. Thank you for all of the wonderful questions and for your engagement, and we'll see you next week.
Great. Thanks, everyone.